Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. Every week on this program, I have a different healthcare professional where we talk about different services, programs, information that I think will be of interest to you and your family. So stay tuned. We'll be back right after these messages with another exciting guest. Welcome back to Your Health Matters. My guest today is Dr. Chris Porter, who's an interventional radiologist here at KRMC. I got that right.
You did. You did.
Thanks for being on the program, Chris.
Thanks for having me.
And we appreciate your being here at KRMC too, because I know you are part of a team of Mayo-trained radiologists that have really raised the bar for Kingman Regional. So let's talk about that.
Well, it's nice of you to say that. I think the greatest part about my job is the people that I work with. Certainly the doctors that I work with. Our group of radiologists, I honestly feel, I've worked at lots of hospitals, is the best that I've ever worked with. And beyond that, the ancillary staff that we have, our crew of nurses, our crew of techs, fantastic. It's taken us a bit of time to get exactly where we are right now, and we have a couple of other things that we'd like to do to get us where we want to be, but I think we're truly running all across the board a really fantastic department right now.
That's awesome. So let's talk about then where you are today. What is it? What are the cool things that you're doing that?
Well, we from both diagnostic and interventional, we're really offering the full spectrum of services. You can receive any procedure here in our interventional radiology department that you will be able to receive anywhere, whether you're living in Boston or Rochester, Minnesota, or Denver, Colorado. We have, with our equipment and with our staff, and now with the ancillary staff and training, we're doing the full spectrum of angiography, vascular intervention, minimally invasive procedures, using our CT scanners and using our ultrasound machines. So it's really exciting.
That is, and so I think if I'm understanding correctly, and from what I've learned about what you're doing as well, that you're basically able to do less invasive procedures, or do procedures now less invasively, that in the past were much more major surgeries with better outcomes, and we're not having to ship people off to Phoenix and Vegas.
Well, our goal, and the goal of my profession, not just here, but across the country and across the world really, is to take things that we've been doing forever and try to figure out ways to do them using technology and apply that technology in a way that allows us to get better outcomes with shorter hospitalizations and less invasive procedures. And there's lots of examples of that. I would say one of the things that in my career that I've seen the biggest change in is people with aortic pathology, people that before required large open abdominal surgeries that required weeks of often weeks of hospitalization after procedures.
And recovery, probably.
Right. Now we're doing these procedures with less morbidity and mortality, and the majority of my patients go home 1 or 2 days after they have their procedure done. So that's just one example of a lot of the different things we're doing here now. You're really not going to get treated better. You're not going to have access to better technology by going anywhere else. And
I think that's important for our audience, for the people of Kingman to know. In the past, everybody always said, oh, it's Kingman, so how big of or how cool of a hospital could they have? It's just a small rural community. But we've grown a lot, KRMC has, I think, to meet the need of our community.
Yeah, we've grown a lot, and I've seen that even in the few years that I've been here. And that's not just my department, but I think it's really a strategy that the hospital has now, and that's it's no longer this every man for himself sort of strategy. We're really functioning in groups and in teams now, and I think as a result of that, we're able to bring lots of different heads in on complicated cases and make the best decisions for patients. And when things happen quickly, when traumas happen, when unexpected surgical outcomes happen, we have groups of people that are trained in multiple different subspecialties who can address those issues and deal with them very, very quickly. So
that's awesome.
It's been really nice, and that's something that's just gotten better.
So Dr. Porter, that's really an amazing thing, and it makes me proud working at Kingman Regional and to see where we've come to, and I know there's plans for more. You've talked about the group that you have worked with are coming together and doing more as a team. The more heads are better, obviously. So is that kind of a Mayo philosophy? Because I know you and a number of your colleagues are Mayo trained.
It's a philosophy that just works better, and I think that we had that ingrained in us being at Mayo, because a significant portion of our day was spent in multidisciplinary meetings talking about patients and complicated cases, and there's more than goes on with a single patient than just lung disease or vascular disease or heart disease, and if I'm going to get that patient in and I'm going to get them set up to have the right care both before, during, and after a procedure. If I'm just focused on that patient's vascular disease and they happen to have lung disease, as most of our patients do, well, then I'm not doing them any service if they have an issue related to that. And so we can involve our group of very talented pulmonologists. We've got a fantastic group of cardiac anesthesiologists that we work with here. Our critical care is top notch.
I've heard wonderful things about it.
And I think that it just really carries across the board. I can do the best procedure in the world, but if I hand off to somebody who doesn't know what I've done, doesn't care what I've done, and the patient has an untoward outcome because they're not being managed appropriately afterwards, I'm not doing them any favors.
It defeats the whole point of what you did.
So you can really have the most talented people operating on people or performing procedures, and it just doesn't mean anything unless the other people in that hospital are up to the same level and communicating. And it's something that we're constantly working on, but I think it's something that I see improving on a daily basis, and I'm really proud of where we're at right now as a hospital in general.
That's great. Now I think, again, people need to be aware of, because the procedures that you do, you're able, like we talked about a little bit ago, but saving even limbs and as well as lives.
Well,
right.
we do a lot of acute lower extremity work, acute upper extremity work. We had a gentleman who came to the ER last night, actually, who had a cold left foot, and actually he's going to leave the hospital today. So we do a lot of that work. We're doing many times several of those cases per day, and our patients are doing very, very well, and we're just happy to be able to provide that service, because prior to that there was kind of limited access to that. So it's nice to be able to be here and to be able to help out with that. I think it makes it a lot easier for the people that live in this community.
So I want to kind of maybe drill down a little bit. You said you came in with a cold left foot, so that means poor circulation, right?
Well, that means no circulation.
No circulation.
Yeah, so basically one of the big vessels that goes and supplies all the flow to your leg, it had completely closed off.
Okay.
So completely closed off, and so we were able to kind of dissolve some of the clot over the course of some time, and then go in and actually find the target lesion that caused it, and open that up, and go and suck the rest of the clot out, and yeah, he's got good pulses in his feet, and hopefully he'll be walking around here.
Wow,
in a week, so.
that's amazing.
Yeah.
I mean, it really is, when you think just a few years ago that would have not been the scenario.
Well, there's always options and alternatives. The alternative to what I would do would be a bypass procedure, which is a time-tested procedure, but that's an open surgery requiring general anesthesia, it's my feeling that if we can avoid that, it's best to. Now, there's always going to be a time and a place for that, but standard of care right now is to try to offer these less invasive approaches first, and then if we get there, then involve our surgery colleagues.
Well, and I think what we're seeing more and more too, that interventional, if you had getting there sooner and addressing those issues sooner, then avoids those late stage major surgeries.
Yeah, one of the things that I've seen here is because there's so many people that do have vascular disease, we're seeing disease here at a very advanced stage. And so we see people with terrible vascular disease who really haven't been cared for. You know, those cases are challenging, but gratifying. You know, I'd like to see this community move towards a place where people have better access to vascular care. People are being screened earlier on, and as a result of that, we're able to catch these things before they get to that point. And you know, I think we're going to move towards that slowly. We started up the KRMC Vascular Center last year.
I was just going to ask you about that.
You know, that's not just for treatment. You know, our hopes is that we're going to be increasing our screening and increasing our diagnostic capabilities. Not really our capabilities because we're there, but rather our outreach. So that we can
building awareness in the community that
building
it's
awareness
options.
And letting them know that this is here. If you're having these issues, if you're at risk for these issues, if you have a history of smoking, if you have parents that have died from heart attacks or had issues with strokes or peripheral arterial disease, think about this. Come in and see us. Be screened. If we can catch these things early, it's a piece of cake to deal with this. We start getting down the road, we get pretty involved, and it's something we can deal with. But I think as a patient, my preference would be to be treated earlier.
Sooner the better. Obviously, your outcomes are going to be better.
Exactly.
And I think probably in the past, people's philosophy maybe even has been, or just thought that that's my family history. It is what it is. I just have to live with it, and when my time comes, and not realizing how far we've come, in just in medical in general, to be able to help with those situations and provide better outcomes.
Right, and I mean, and honestly, the best thing that anybody can do for themselves is stop smoking. Right. So so that's the best thing you can do, and nobody watching this is going to that's I'm not surprising anybody right now, but stop smoking. Number 2, get in, be screened, have your labs checked.
Is that kind of like for a benchmark almost? You do initial screening and then watch?
As a benchmark, or you might even have problems that you don't even know about. And so have your labs tested. Make sure your cholesterol is in the ballpark. This is it's such an easy thing to treat. Make sure your blood pressure is under control. Such an easy thing to treat. Get set up with a little bit of exercise. Get screened. Let's make sure there's not anything going on with the vessels going to your heart, the vessels going to your head, the vessels going to your legs. Certainly anybody who's smoked should have their abdominal aorta screened. This is something that's life-threatening. If you haven't, you don't know about it. But these are things that talk with your primary care doctor about, and then they can consult with us and involve us to whatever degree they feel is appropriate, and we'll get it taken care of.
Okay, so that's what I was going to ask was, so the process is you would go to my primary care physician first, and they would do the referral.
Right.
To
so I don't take primary referrals, but keep in mind, the KRMC Vascular Center is here, interventional radiology is here, and so when you go to your primary care doc and you say, well doc, you know, I am having a little bit of discomfort in my legs when I'm walking, I'm having some non-specific belly pain, I'm having chest, etc. You know, let's get this checked out. Let's get this checked out. The referral can very easily be made to us, and we're happy to see you. Happy to see you and take care of any of the issues that we can.
Okay. And what are the kind of things? So what kind of a procedure are you doing for that diagnostic? Is it X-rays? Is it a CT scan, or?
Well, it really depends on what problems you're having. Okay. You know, we offer the full spectrum. So here we have excellent MRI, we have excellent CT, we have excellent ultrasound. CT gives us great images. CT also exposes people to contrast and a little bit of radiation. And even though it does give us the best images, a lot of people have vascular disease. Sometimes their kidneys don't work as well as we'd like them to.
So it's not going to move the dye through.
In those circumstances, then we can move either to MRI or ultrasound testing. The least expensive and easiest way to screen people for peripheral arterial disease is ultrasound with ankle brachial indices, or ABIs. It's a quick procedure, no radiation, no contrast, and we're able to tell you, are you getting enough blood flow to your legs? And then we can kind of put that into the context of what your clinical symptoms are, and hopefully make a good treatment decision for you.
Okay, very good. Well, that's very interesting. We're going to take a quick break, and then we'll be right back. So I hope you'll stay tuned, because we've got a lot more to talk about.
Oh no, I thought I was probably going to be a professional fisherman or something like that.
Welcome back to Your Health Matters. My guest today is Dr. Chris Porter. Thanks again for being on the show, Chris. Dr. Porter, you've talked about all the different types of interventional things that you can do for patients. When we were talking earlier about with the vein work, and you were saying the difference of catching it early was the difference between a full blockage or, what was the word you used?
Well, an occlusion.
Okay.
So it's smaller areas of narrowing. You know, some of these areas of narrowing can be small enough that we can reverse them with medicine alone.
Oh.
You know, once we get to a certain point, then we're talking about opening these areas up, maybe with a balloon, sometimes with a device that actually is able to remove the plaque from the inside of the vessel.
Kind of like going to the dentist?
Kind of, yeah, kind of. And sometimes we even put stents in. And so these are fairly easy things to treat most of the time. Once we get to the point that these areas of narrowing become very high grade or even turn into occlusions, things can be quite a bit more involved, and our success rate with long segment occlusions of arteries tends to go down a little bit. So longer procedures, more challenging procedures, and you know, our likelihood of success, although it's still very high, tends to dwindle a little bit.
Sure, it just makes sense. Well, and if someone has gotten to that point, their overall health has probably already been impacted some too, right? So
right, and I think it's indicative of things we could have done better all the way along. So if I'm seeing disease in the legs, there's almost always going to be disease in the heart. There's almost always going to be disease in the other vessels. So it's more of a global issue, you know, and we're just trying to kind of catch things as they arise.
Well, and I think it's important, you mentioned before the break on our earlier segment, the importance of quitting smoking, exercising, eating healthier,
weight loss,
weight loss, all of those things are going to impact your long-term health, obviously, and how you can recover even faster.
Right.
You do have the procedures.
Right, and I would, you know, first thing I would do whenever I see a patient is I want to encourage them, stop smoking, wake up in the morning and go on a walk, eat healthy food, maintain or try to improve your weight. These are all things that we have control over every single day we wake up, and I just encourage people, you know, if you can't work out every day of the week, I appreciate that. We all have busy lives. Do it a couple days a week. Just try to improve. Try to make yourself better.
Even at lunch, going for a lunch walk.
Just a quick walk. Anything is better than nothing.
Right, absolutely.
Yeah.
Now, so when a patient comes to you, they've already seen the primary care physician, they've gotten that referral, but do you end up taking that patient at that point? How does that work?
So the referral would be made to my clinic. And
Okay,
you can make the referral could be made either to the KMC Vascular Center or the referral could be made to interventional radiology.
Okay.
And if you call, or the primary care doctor calls up the hospital operator, that can easily be arranged. They can also call up my personal scheduler, and that's at 263-3830.
Okay.
And if there's any questions as far as how that referral path or what the best way is to establish that referral path, then we can answer those questions for you.
Okay, but that is what's nice about the vascular center. It's almost become a one-stop shop, like we were talking about.
And so I am not the vascular center. I actually work with Dr. Dennis Dunning. He's a cardiologist, does great work, and we both do things better. And in some cases, we do things that the other person doesn't do. And so what the vascular center allows us to do is to take patients in and try to decide who's the best person to treat that patient, to talk about that patient in complicated scenarios, and ultimately to provide the best care for that patient, depending upon what their condition is.
Okay, awesome. So I would like to fill in our audience a little bit about how you got to where you are today.
Yeah.
Because so did you know you always wanted to be a doctor?
Oh, no. I thought I was probably going to be a professional fisherman or something like that. You know, it was after my first year of college. I spent a little bit of time trying to figure out exactly what I was going to do. One of the things that I did is I was a technician in an emergency department. And that was when I was just turned 18.
Oh, so that was an eye-opener for you, I bet.
Right. I was doing a few different things at the time, but what I really liked about medicine was that I found that in a lot of other places that I worked at, people really didn't seem to be as well trained or as responsive. And I felt like when I was working in a hospital, I felt like I was surrounded by people who really wanted to do a good job, people that were all aim towards towards I guess the same goals, and things happened quickly, and everybody had their place in that team, and that was appealing to me because I wasn't seeing that in some of the other places that I was spending my time. So long story short, finished up the rest of college, went to medical school at University of Colorado. Then I moved to Minnesota to spend several years at Mayo Clinic, and then I moved to University of Virginia shortly thereafter to complete my subspecialty training in vascular and interventional radiology.
Okay.
And after that, been here for the last couple of years.
Right. So how did you pick Kingman?
Well, that was I would say the biggest driving force here was that the gentlemen in my practice were people that I went to residency with at Mayo
Right.
Clinic. And we had an opportunity to come down here. And it's funny, everybody kind of has this dream when they go to medical school that they're going to make a big difference.
Sure.
And sometimes when you're towards the end of your residency and you're thinking, well, I'm going to go work in Chicago with a group of 5 other interventionalists, and well, it'll be great. Well, the reality is that there's 5 other interventionalists at that practice who can in many cases do what you can do, and you're helping their practice out. You're giving everybody a little bit more vacation, I guess. But in the end of the day, you're probably not changing how healthcare is delivered to a community. And so all of us had an opportunity to come down here and build a practice where we felt like, well, gosh, maybe we can change something. Maybe we can go into a community and really change the way healthcare is delivered. And I think for all of us that was kind of a little bit romantic, but kind of something that we had all set out to do from the get-go. And so being able to come here, possibly improve the delivery of healthcare and work with the people that I do, it's just been great.
You're making a difference. And I think that's one of the things that in a community like you've mentioned, and I say this often about Kingman, is that we're small enough that you can see the things you're doing and how you're changing and making it a better place. Right. And I think that that's really happening for your team as well.
Yeah, and we see that, and the nurses we work with see that, and our techs see that, and we don't go to the grocery store without seeing our patients anymore,
right.
and that's fantastic. Yeah. Because you get to see those people and you get to see their grandkids, and
they're up walking around,
and I just love it. I just absolutely love it. So it's been so nice.
That's awesome.
Nice, yeah.
And so now you have a young family, so you're going to raise them in a small town community where they'll get to know everybody as well.
Yeah, and my son's got lots of good buddies already, and he's just running around like a crazy guy, and
That's awesome.
and he's grown up in the mountains, and you just can't get any better than that.
Right. Yeah, it's a good life, and not quite as cold. People that come from the Midwest, I always have to remind them how much better it is here.
This is well, for somebody like me, I grew up in Colorado. I was there for 28 years, and I love Colorado. But I like the culture of the West. But I also like the warmer weather. And having lived in Minnesota for so long, I appreciate the people that do that. But that's just not. It wasn't for me. And so living here, where I get that really a good Western culture, I get to live in a small town. I have beautiful summers, springs and falls, and then I get just a touch of winter. Perfect.
Yeah, it's my idea of a perfect winter. That's what I tell all the time.
Yeah, it's perfect. We get a few days of snow, and well, that's enough for me. I haven't had to shovel my driveway once.
Yes, I know. Yeah, it makes a big difference.
Yeah.
And you can have a livable winter where you're able to still get out and do things.
Exactly.
So with your team that you're working with now, the 5 of you, and I think you've all been through Mayo, so you all had that Minnesota experience as well. But so it's a good support network then for each other too, right?
As you build a practice or build anything, struggling through those things alone, I think develops its own level of character. But having somebody else there who's kind of going through the same things and maybe having a touch better day than you are, somebody who you can talk to, professionally, it's been great. Personally, having those friends to spend time with outside of work, it's been great. They're great families, good people, and just a good life. Really.
That's great. Yeah. So do you kind of take turns doing, because they're all radiologists, right, in your team?
That's right.
So, but they all have different specialties. Is that right? Am I saying that
Yeah, we all
right?
have different specialties, but the nice thing about where we train is that we all have a fairly strong foundation in just general radiology, and in fact, the gentlemen that I work with are actually also very good at most of the interventional procedures that we do. And so when we talk about kind of splitting that workload, we have subspecialty stations, and we try to keep everybody in the spots where they're trained, the spots where they are the strongest. But we can easily float back and forth and cover each other and provide different perspectives. I think just because of the strength of our training in residency.
That's great, and it's a huge benefit for Kingman and for KRMC, but for our community as well. I think we've talked about before that in the past, one of the biggest challenges for KRMC was not just that we didn't have the doctors of your caliber, but that we didn't even have all the equipment we needed and those kind of things. So many people got shipped to Vegas or to Phoenix, and to be able to keep them here is a wonderful gift.
Well, I think the hospital has spent a lot of time thinking about this and spent a lot of money trying to get the right equipment so that we can do the work that we do. The current equipment that I'm working on is better than the equipment that I was using a few years back at Mayo, actually.
Awesome.
So the hospital brought a brand new Siemens C-arm over for us, and this is state-of-the-art technology. It's so good that, we talked about contrast, but contrast is basically a medicine that we inject so that we can see the insides of the blood vessels and see enhancement patterns and organs, and our technology is so good that instead of using some of the more I don't want to say toxic because it's not toxic, but some of the contrast mediums which can cause kidney issues, we're actually able to use air, CO2, because our equipment is so good that we can actually see the differences in density between air and the body tissues and use that instead. And so being able to use air as contrast, we don't damage the kidneys at all.
Wonderful.
And so we're able to apply that in a lot of our patients that have vascular disease, kidney disease, et cetera.
Very good.
Yeah.
Well, thank you so much for being on the program today,
thank you.
Dr. Porter. Time flies when you've got such interesting topics. I hope you learned something today. I did. And you'll join us again next week when I'll have another exciting guest on the program.